It's a pleasure to introduce Dr. Ikonomidis.
Ikonomidis.
Oh, thanks. Consultant in the Clinic of Cardiology and Electrophysiology of Evangelical Hospital at in Georgia. He will take a lecture about the cardiologist's point of view in autoimmune arthritis. Please.
So he's a different person.
Hello, it's Professor Ikonomidis from Atcon Hospital, but indeed I will discuss about the cardiologist's point of view in autoimmune disease. Let me make a full screen of my talk. And I'm working in the second cardiology department of Atcon Hospital, and we do run some sort of collaboration with rheumatologists and dermatologists regarding psoriatic arthritis and rheumatoid arthritis. And I'm going to discuss about our point of view in assessing these patients from the pathophysiological point of view and, of course, from the clinical point of view. In an elegant review that we published in Cardiovascular Imaging, we have shown that there is a close association between autoimmune rheumatic diseases like rheumatoid arthritis and lupus and psoriasis and psoriatic arthritis as well, with all the scale of the cardiovascular diseases regarding LV systolic dysfunction, diastolic dysfunction, and of course coronary microcirculatory dysfunction, myocarditis, pulmonary hypertension, valvular heart disease. And of course, inflammation plays a role. Why? Because it affects the endothelium by increasing the circulation of inflammatory factors and increasing the oxidative stress and impairing the endothelial function. And this is a key point that causes further thrombosis, further inflammation, vasospasm, and of course, it creates the procedures that lead to atherosclerosis and again, possible plaque rupture leading to acute coronary syndromes. So the inflammation is targeting endothelial, and plus patients with rheumatoid arthritis and autoimmune disease usually have a high incidence of other traditional risk factors, increasing their risk for coronary artery disease and cardiovascular events. And of course, we can see here that hypertension is present in about 19-20%, diabetes mellitus from 6 to 7%, hyperlipidemia up to 11%, and of course obesity up to 6%. And also we know that autoimmune diseases cause the release of interleukin-1 and interleukin-6, and interleukin-1 has a direct myocardial suppression action either through action on cell mitochondria and production of peroxynitrite, but also inducing the release from the liver of interleukin-6, which also has a direct negative inotropic effect and affects contractility. Plus, interleukin-1 through oxidative stress may increase apoptosis of the myocardial cells per se. So there is an interplay between synovial inflammation, circulation of inflammatory markers like TNF-alpha 1 and 6, and all these may cause insulin resistance, increased oxidative stress, prothrombotic state through actually endothelial dysfunction, changes in blood pressure, and changes in body composition. Actually, when we assessed patients with psoriasis and we measured interleukin-6 level, we have seen that the patients with psoriasis had similar levels to those of coronary artery disease and significantly higher than controls. And these patients of psoriasis and coronary artery disease were matched for other factors that may lead to elevation of interleukin-6. And we know again that the combination of inflammatory factors, endothelial dysfunction, increase in angiotensin II receptor reduction of NO, and increase of endothelin may all cause heart failure with preserved ejection fraction. So the inflammatory diseases, to sum up, may cause endothelial dysfunction, increase arterial stiffness, cause myocardial fibrosis, RAS activation, and more importantly, impaired calcium handling and mitochondrial dysfunction. And all this may cause heart failure. And indeed, we have shown, for example, that in the interleukin-6 receptor antagonist, cilizumab, reduces the elevation of troponin, reduces the myocardial damage in acute ischemic syndromes. And there have been several studies showing the close link between rheumatoid arthritis and the risk of ischemic and non-ischemic heart failure. And you can see here that particularly for ischemic heart failure, the relative risk increases as the duration of disease increases. When it is 10 years, it is nearly double the risk for ischemic heart failure, whereas for non-ischemic heart failure, this may be true for even the first year of the diagnosis of rheumatoid arthritis. And this is because rheumatoid arthritis inflammation is clustered with the other risk factors promoting atherosclerosis and acute cardiovascular events. This is actually what these slides show, that the incidence of heart failure among rheumatoid arthritis of any duration is about 1.5. What other factors play a role for the incident heart failure? Of course, the activity of the disease. The higher the CRP, the higher the ESR, the higher the DAS score and HAQ score that they show increased disease activity, the greater the risk for heart failure. And these are the conclusions of this study, that high disease activity was associated with all heart failure types. However, the duration of the disease is closely related to ischemic heart failure. And of course, there are factors like RF and CRP that are closely related to heart failure. So there is an interplay of the acute direct effects of inflammation on vessels and myocardium, but also a combination with the risk factors that causes to ischemic heart failure at a later stage. We know from the EULAR that this has been recognized, and what is proposed that in patients with RA, psoriatic arthritis, and ankylosing spondylitis, SCORE CVD prediction model should be used. And as we will see further down, we should multiply it with 1.5. So we may not have a direct evidence of plaque, for example, as you discussed before with Dr. Pepe, but if there are several risk factors, in addition to the presence of rheumatoid arthritis, then the risk may be high, and then there may be an indication of statin independently of the LDL levels. And what is suggested here is that we should treat immediately the disease activity, and biological agents are quite effective on this issue, and avoid corticosteroids or non-steroidal drugs because this may exacerbate the danger for future cardiovascular disease. This is also presented in the 2021 EC guidelines, that we should multiply the risk, and the risk score is derived from the presence of the classical risk factors like age, hypertension, lipids, and smoking, and of course gender, male or female. And you estimate very easily through your iPhone. There is an application, you put these factors together and you get a score. And if, for example, the score is 5 and you multiply it by 1.5, then you get close to 10, and after 10, one should be treated with a statin. And of course, the guidelines recognize that rheumatoid arthritis is a risk factor for heart failure. However, anti-TNF agents should be avoided because they may worsen heart failure, and other biological agents should be used. Also, in terms of acute myocarditis, again, rheumatoid arthritis may cause acute myocarditis, and this has to be in mind in cases where we have symptoms like dyspnea in our patients. This is a patient with a systemic lupus erythematosus with an acute myocarditis. You can see how thick are the walls here because of edema, and of course you can see the presence of pericardial effusion. Similarly, ankylosing spondylitis disease has been linked with cardiovascular disease, particularly in the male subgroup, and this is also something that we should bear in mind, with 1.3 times higher risk for cardiovascular disease. Another more common disease is psoriasis, and psoriasis can be with or without arthritis, and these are studies stating that the danger is about 1.5 higher in patients with psoriasis, and this also is true for psoriatic arthritis patients, and this also is related with disease activity, and you can see here that a severe form of psoriasis is related 1.3% for CV death, 1.7 for myocardial infarction, and 1.56 for stroke. Now, several other arthritis like uric acid arthritis may be also linked with cardiovascular risk, and this again may be mediated through oxidative stress, inflammation, myocardial fibrosis, and cardiac remodeling. Inflammatory bowel disease also is an inflammatory situation, also close linked to coronary artery disease events, either STEMI or non-STEMI. And you can see here that the adjusted risk is 2.6 in these patients. In our laboratory of preventive cardiology and echocardiography, we have established a close association and common examination of patients with autoimmune diseases, if they come from rheumatologists for RA or SLE or systemic sclerosis, or from dermatologists from psoriasis and psoriatic arthritis, and we check myocardial function using myocardial deformation techniques and echo. We do coronary flow research to assess coronary function, and we assess endothelial function by FMD and by measuring the endothelial glycocalyx. Now, we know that the diagnosis of chronic heart failure is more likely in patients that they have a history of chronic kidney disease, and in NT-proBNP may be very helpful in these cases to diagnose. So in case that echo is not available, the measurement of NT-proBNP in the guidelines and should be used from a rheumatology that he is afraid or she is afraid that his or her patient may have heart failure because of myocarditis, because of HFpEF, we present ejection fraction. So an NT-proBNP value greater than 125 should guide the patient to more exclusive cardiology examinations. And this will include, of course, echo with ejection fraction, 50%, for example, tissue Doppler, left atrial diameters and thickness, the pulmonary arterial pressure measurement by measuring PR velocity, and of course, the atrial fibrillation. And of course, we can combine data from echo and NT-proBNP and see if we get more than 5 points, then for sure our patient has heart failure with preserved ejection fraction. And of course, if the ejection fraction is low, is impaired, then we have an overt heart failure with reduced ejection fraction. CMR is very important. This is one of the studies showing the value of CMR in patients with connective tissue disorders by Sofia Mavrogianni and others. They assessed several patients with vasculitis, sarcoidosis, SLE, and rheumatoid arthritis. And of course, you can have very nice pictures as this one, where you can see the damage using combination of T2 series showing the effects. Was able to identify these patients with damage on myocardial, and stress studies are also useful to exclude coronary artery disease and to be more sure that this kind of damage is due to the disease itself and not to coexisting coronary artery disease. So this is also another study showing the value of CMR in patients in assessing the presence of scar, epicardial, intramural, or transmural, and of course assessing the LV mass and assessing the extracellular volume, which also may be a useful factor, especially in minor lesions, and check the effects of inflammation on myocardium itself. Scintigraphy is very useful, and it has been used by PET intake of the aorta in showing these very nice yellow spots, which are plaques, atherosclerotic plaques with high inflammatory activity, and has been used to assess the inflammatory burden on our plaques. CT angiography also can show calcium score, and of course may do see the napkin ring sign, which is very important as it shows increased activity of the plaque. And of course, we can assess in our patients other surrogate markers like coronary flow reserve or flow-mediated dilatation, and see the effect of psoriasis and psoriatic arthritis. And we have seen that in these patients, endothelial dysfunction, PBR shows the endothelial and cocalyx thickness, coronary flow reserve, flow-mediated dilatation, and myocardial dysfunction, showing a very sensitive marker that may be impaired even with preserved ejection fraction, is impaired in those patients compared to controls. And of course, we know that, for example, this very sensitive marker of myocardial deformation is associated with prognosis in patients with rheumatoid arthritis. You can see here, the more impaired the GLS, the higher possibility of hospitalization for all causes and for cardiovascular hospitalization. And this is another study that we have recently published assessing the additive value of GLS, of this global longitudinal strain, a very sensitive marker of myocardial function, to score. We previously said we have to assess score in all our patients. And we have seen what happens when GLS is impaired at baseline, and what happens if we give biological agents and this GLS is improved after six months of treatment. And what we have seen is that we use the baseline GLS, every 1% lower GLS causes 1% higher probability to have an event. But if we lower it, then we have a 33% reduction in the risk of MACE in our patients with psoriasis. These are the Kaplan-Meier curves using as a cutoff the 16%, which is a good cutoff, as this is considered a cutoff less than 60% in any case, in any patient. It shows some sort of impairment of myocardial function. And you can see here the independent value of GLS. Arterial stiffness in an unadjusted analysis plays also a role. Also, hyperlipidemia, diabetes, hypertension. This is the univariate analysis. However, in multivariate analysis, diabetes and GLS were the most strong predictors of risk in this group of patients. And of course, you can see here that the use of drugs like NSDs are linked to increase of hospitalization for heart failure. That's why the EULAR suggests to avoid this medication. Probably only celecoxib may go out of this, but however, other drugs like usually like ibuprofen is strongly related with an increased odds ratio for heart failure. Another interesting drug that has been used in rheumatoid arthritis is interleukin-1 receptor agonist. We did a very nice study in the past, and we randomized rheumatoid arthritis patients. We used this as a model to assess the effects of interleukin-1 on vascular function, myocardial function. So we had an acute phase, double-blind crossover trial of anakinra to assess the effects on coronary flow reserve, endothelial function, and on markers of inflammation like CRP, interleukin-6, MDS, markers of oxidative stress, and endothelin. And then all patients received anakinra for 1 month, and we used as a control for this month patients treated with prednisolone. And we found that in acute phase also, but in a chronic phase, we had an improvement of endothelial function as assessed by flow-mediated dilatation, an improvement in aortic distensibility, also improvement in the coronary flow reserve. And this was associated with significant reduction of MDA, nitrotyrosine, interleukin-6, endothelin-1, and CRP levels. And of course, these changes were not evident in the control group of prednisolone. Also, we used another study population that had rheumatoid arthritis and coronary artery disease at the same time. And we have seen, of course, that the higher the interleukin-1 levels at baseline, the more impairment in terms of global longitudinal strain, and the more improvement that we had after interleukin-1 inhibition, the greater improvement was global longitudinal strain. And this also affected the normal kinetic segments, stating that there was inflammation without impairment of wall motion. And I can show you here an example. This is a patient that came with chest pain. This is a very abnormal ECG with negative T waves. And this is 7 days after anakinra, patient with rheumatoid arthritis and chest pain. And you can see here a resolution. There was hypokinesis of the apex in this patient. We did some contrast studies. You can see here there is a lot of black. There is no contrast in the myocardium. 7 days. There is good movement of the apical segment, and all is yellow because there is uptake of the myocardial contrast. And this is the coronary flow at admission, basal flow after adenosine. And this is 1 week after. You can see the higher increase, the higher response to adenosine after proper treatment with interleukin-1 with anakinra, how low was the response with adenosine, how high was the response after adenosine 1 week after treatment. And this is the GLS. This is the number 16% before treatment, 25% post-treatment, so it was normalized. We also did studies with another interleukin-6 inhibitor, tocilizumab, a similar study, and we have found a similar improvement in GLS and, of course, in coronary flow and in pulse wave velocity after the use of tocilizumab, interleukin-6 inhibitor. Now, in psoriasis, again, we checked the various biological agents, ustekinumab, etanercept, cyclosporine, and what we have shown is that the greater effect was after interleukin 12-23 inhibition in our patients in terms of arterial stiffness and coronary flow. And of course, the same is true for GLS. You can see a 20% improvement and the 14% improvement compared to the other two agents. And this again was through an improvement in oxidative stress as measured by TNF and a greater improvement in TNF in NT-proBNP levels. Interleukin-17 has similar effects and like secukinumab in the same group of patients, again, GLS is improved, and this improvement is steady at 1 year's follow-up. Finally, apremilast is a Peros agent used in psoriasis, and I think is one of the agents that showed a great increase in GLS, but also in endothelial function. We know also from other studies that biological agents have a good effect on endothelial function and is measured with FMD, and tocilizumab is more effective than anti-TNF and, of course, DMARDs. Now, treatment with TNF may at least restore coronary microvascular function in young patients with severe psoriasis. This is one of the studies. However, what has been shown, as we said, for plaque characterization, in this study that they did CT angiography and they measured the volume of the plaque and the composition of the plaque. Patients that were under biological agent, they had a reduction of the total plaque volume, whereas those that were treated without biological agents, this plaque increased and became worse during the follow-up period. So it appears that the biological agents may have a direct effect on the progression of atherosclerosis. And this is another meta-analysis showing that the use of biological agents is very effective in improving prognosis and improving mortality in patients with systemic cirrhosis. And this goes along with our study that was recently published. So current biological use of these biological agents is suggested in inflammatory arthritis to reduce and improve prognosis. And we believe this is true because these agents affect both myocardium and both vascular function. And this is a consensus paper where we suggested to use biological agents to improve ventricular arterial coupling and reduce the risk of heart failure and further coronary artery disease events. CANDUS is a study that has shown, not of course in rheumatoid arthritis disease patients, but in chronic arthritis disease, that this kind of the approach is effective. And for example, in CANDUS, those that had a SERP level less than 1.8 after the first dose were the ones that had the most effect. So if you have an increased CRP, and if this CRP is lowered, then you have a very good response, and this is a good subset of patients, and CRP is a good way to monitor the effects of treatment. Now, in terms of how to diagnose early coronary artery disease, we suggest this is what we suggested as an algorithm in our JACC imaging paper. In asymptomatic patients, assess the cardiovascular risk, multiply it by 1.5, and if low or moderate, reassess using cardiac ultrasound. And if you find a large plaque, then the patient is eligible for statins and maybe for further assessment. If also one can do CAC score, calcium score, and it is high, then again one should also use statins to prevent further increase of the atherosclerotic procedure as assessed by the presence of CAC score of carotid plaques. Now, of course, if we have chest discomfort in our autoimmune patients, then we should check for presence of pulmonary disease by chest X-ray or CT. If coronary artery disease or myocarditis or valvular heart disease is suspected, then of course echo and MRI should be used to evaluate structural disease and treat accordingly the presence of heart failure or perimyocarditis. If there is a normal echo, then we should assess the pretest probability for coronary disease if our patient has a typical pain, had borderline ECG, several risk factors, then a non-invasive test of ischemia like stress echo or CT coronary angiography should be performed. And of course, then if there are findings, we should treat them with coronary angiography. Of course, if there are wall motion abnormalities and there is typical angina, then medical treatment and coronary angiography is imperative in these patients. So as take-home messages, patients with inflammatory arthritis pose a higher risk for developing heart failure. Inflammatory arthritis and atherosclerosis are common pathophysiological pathways that are elicited by immune system. Utilization of novel echo techniques, CMR, coronary CT scan allows early and accurate recognition of cardiac involvement, and clinical studies show that treatment with tailored biological agents, in addition to controlling inflammatory disease, has significant beneficial effects on myocardial function, may prevent the progression of cardiovascular disease, and may also improve prognosis in these patients. Thank you for your attention.
Thank you, Professor Ikonomidis, for your great lecture, for your huge work and research in this field. Sofia Mavrogeni has some comments for us. Please, Sofia.
Okay, thank you. I have to say thank you to Professor Ikonomidis. It is really a great work that shows his very high scientific level, and we enjoy it very much. But the point is, echocardiography has also some limitations. In the recent ESC, it was told that even in the most experienced hands, only 70% of echocardiographic studies are diagnostic. I don't like to discuss what is the diagnostic capability in less experienced hands. So it's nice to have all these indices. However, it doesn't work in everyday practice in every echo machine. And for this reason, it has not been, these indices have not been included in the, let's say, routine echocardiographic assessment. So it's nice to be able to do everything by echo, and some people can do, like you, but it's not easy to do everywhere under all circumstances. On the other side, you said that supports that we should not use anti-inflammatory treatment, at least in some cases. But maybe the bad effect of this medication is not only due to this medication, but to the inflammation percent. I mean, these patients with rheumatoid arthritis have 4 times higher incidence of heart failure, irrespective of presence of coronary artery disease. That means we miss some events of inflammation in these patients, and we miss it because we don't have the right tool. The third thing is that the thickening of septum is a finding that we can find only in 10% of myocarditis. It's not the everyday routine in myocarditis to see the edema by echo. And for this reason, we developed CMR. So we have to take all these parameters under consideration. Echo is a very powerful tool. Of course, I have it in my private, and all of us will use it. However, we cannot answer all questions using echo. Thank you.
Yeah, I agree. Or if we want to do a tissue characterization and see the extent of the insult of the inflammatory disease on myocardium, of course, CMR is good, is excellent, because you can have the extracellular volume as well, which is very important to assess the fibrosis. However, you see, echo is a bedside tool, so you can have easily, for example, by measuring the tissue Doppler markers of diastolic function and the myocardial deformation markers. And of course, these have been implemented in the assessment of HFpEF in now consensus papers. GLS is only to assess subclinical function in the American guidelines for marker regurgitation. However, there is an increased tendency to use it, for example, in cardio-oncology patients, as the first step to check if there is a significant impairment. And this holds true also for rheumatoid arthritis patients. So it is a useful tool, and it is very easy to measure it because nowadays most of the machines have the software and it's automated. You have the AFI function, and nearly most of the machines have the AFI. So if you have a good image, you get a good result. And with an automated way, and you have a quantification of that. It's not qualitative, but it is quantified. So everyone is encouraged to use it because it is there on the machine, and of course, it is only a marker, and you use it according to the symptoms of the patient and the rest of the clinical situation and entity. CMR is great because, and of course, other techniques. I don't know if CMR can also do some characterization of the plaque. I heard some talks yesterday that this may be the case for CMR as well. And that would be very interesting in these patients that they have high inflammation to see if there is a high risk for a future event. And of course, if by using our biological agents, we can regress a soft plaque and make it stable and reduce the lipid core of the plaque. So all these are very interesting research work that we need to develop it further.
Thank you for your reply. Unfortunately, we have to close due to time constraints. I would like to thank all the speakers for their great contribution, and so we have to move to the next session.